Yes, yes, ma'am, you are audible.
Yes, yes. Thank you for your kind introduction, Dr. Ravi. Good evening, all. Today I am going to talk about the insulins, the exploring evidence with next generation insulins in hospitalized patients. Next slide, please. This is my financial disclosure. Next slide. Today's agenda is divided into two parts. First part is next generation basal insulin in hospitalized patients, and second part is ultra fast insulin as component of basal bolus regimen. That is ultra acting insulin, basal insulin degludec, and fast acting insulin, insulin aspart. So there is good evidence with the use of insulin degludec across randomized controlled trials and real world evidences. Next slide, please. These are the various trials. Randomized controlled trials and real world evidences have shown consistent efficacy and hypoglycemia benefits with degludec in outpatients with type 2 diabetes mellitus. The randomized controlled trials are Begin trial, Switch trial, Devote trial, and Conclude trial. These trials are compared with Glargine U100 and Glargine U300. So, in Begin trial, the comparator is Glargine U100, and the reduction of the HbA1c is more or less same with the insulin degludec and with the insulin Glargine U100. And coming to the fasting plasma glucose reduction, there is significant reduction of the fasting plasma glucose with insulin degludec when compared with the insulin Glargine U100 in insulin naive patients. And coming to the dose, there is a significant reduction of the dose of insulin degludec when compared to the insulin Glargine U100 in reducing the plasma glucose, fasting plasma glucose. And coming to the incidence of hypoglycemia, there is significant reduction of the hypoglycemic episodes with the insulin degludec when compared with the insulin Glargine U100. And coming to the switch study, in this study, the degludec is compared with the Glargine U100. The HbA1c reduction is same in both cases. And coming to the fasting plasma glucose reduction, the insulin degludec shows superior reduction of fasting plasma glucose compared to the insulin Glargine U100, and the dose is also reduced dose when compared with the Glargine U100, and the hypoglycemic events are very much less when compared with the Glargine U100 with degludec. And coming to the Devote trial, the comparator is Glargine U100. HbA1c is more or less same in both cases, and the fasting plasma glucose is also significantly reduction of the fasting plasma glucose with insulin degludec, and there is an increase in the dose of degludec in case of Devote trial, and the hypoglycemic incidence is less with insulin degludec. In Devote trial, mainly this trial is conducted to assess the risk of major cardiovascular events, that is MACE, as the primary endpoints and the secondary endpoints. In the primary endpoints, there is no much difference in between two, insulin degludec and insulin Glargine. When coming to the secondary endpoints in this trial, Devote trial, there is significant decrease in the occurrence of the 3-point MACE with insulin degludec when compared with the insulin Glargine. It shows the superiority over the insulin Glargine U100. And coming to the Conclude trial, this trial, the Glargine U300 is used as a comparator, and the HbA1c is reduced. Reduction is more with insulin degludec when compared with the Glargine 300, and fasting plasma glucose reduction is more, and dose reduction of dose is more. And coming to the hypoglycemia, there is reduced hypoglycemia with insulin degludec. And coming to the real world evidences trials, these are U-treat trial and Confirm and Reflect. And in the U-treat trial, the insulin degludec is compared with either basal insulins like insulin Glargine U100 or Detimir or neutral protein has run insulin, NPH insulin, and coming to the results, the reduction of the HbA1c is superior to all other basal insulins with insulin degludec, and the dose is requirement is also less with insulin degludec, and hypoglycemic events are very much less with the insulin degludec. There are significant differences. And coming to the confirmed trial, in this trial the comparator is glargine U300. The HbA1c reduction is more with insulin degludec, and the dose requirement is also less with insulin degludec, and hypoglycemic events are less with insulin degludec when compared with the glargine U300. And coming to the reflect trial, in this trial the basal insulins prior to switchover, the HbA1c reduction is more with insulin degludec, and fasting plasma glucose reduction is significant difference in the fasting plasma glucose with insulin degludec, and with the glargine there is no difference in the dose of glargine, but U100, but with the reference to the hypoglycemia, the hypoglycemic events are very much less with insulin degludec. Next slide please. This slide shows lower within day glycemic variability with degludec than glargine U100. The dark blue color shows the degludec, and grey color shows the glargine U100. The right hand side graph shows the x-axis shows the time interval in hours from 0 to 6, 6 to 12, 12 to 18, and 18 to 24, and y-axis shows the proportion of area under curve glucose in range percent. And degludec when given in the dose of 0.4 units per kg in 22 patients, the baseline is on 25, and the 23% showed the glucose within the normal range, and 28% just above, a little above the normal range, and 26% just within the normal range, and 23% within the normal range even after 18 to 24 hours. This shows there is very less glycemic variability within the day with insulin degludec when compared with the insulin glargine. Coming to the other slide, other graph, the insulin glargine U100 when given in the dose of 0.4 units per kg body weight, there is a significant elevation of blood glucose. In 0 to 6 hours, the 31% shows above the target, and after 6 to 12 hours, there is 29% showed above the target, and after 12 to 18 hours, 23% show below the target, and after 18 to 24 hours, 17% are below the target. This shows high glycemic variability is seen with the glargine U100. This leads to occurrence of the nocturnal hypoglycemias when compared with the degludec. The total glucose lowering effect was more evenly distributed across a 24-hour dosing interval with degludec than glargine U100. Next slide please. So lower within a day glycemic variability with degludec than glargine U300, sorry. So the degludec when given in the same dose 0.4 unit per kg body weight, this graph shows the more or less same, there is no much glycemic variability with the degludec when compared with the glargine U300. The glargine U300 shows the gross differences in the glucose area under curve in glucose in range, varies from 0 to 6 hours it is 35, and after 6 to 12 hours between it is 20, and 12 to 18 hours it is only 17. So there is significant variability of the glucose which leads into hypoglycemia, and after 18 to 24 hours there is still increase in the glucose levels of 28. So the degludec has had approximately 40% lower within day variability in glucose lowering effect compared with glargine U300. Next slide please. So day-to-day glycemic variability is lower with degludec versus glargine U300 and U100. So first slide shows the insulin degludec versus insulin glargine U100. So x-axis shows the various timings from 0 to 2 to 20 to 24 hours, and y-axis shows the day-to-day variability in area under curve, glucose in range, coefficient variation, and the blue color is insulin degludec and dark brown is the insulin glargine U100. So in all cases of with insulin degludec at any point of time from 0 to 24 hours, there is no much variability. There is no much variability of the glucose levels. That is, glycemic variability is very much less with insulin degludec when compared with the insulin glargine U100, where it is it peaks around 12 to 14 hours and it slowly comes down to 20 to 24 hours. Still, there is a gross variation of blood glucose levels with insulin glargine U100. And coming to the insulin degludec versus insulin glargine U300, the other graph shows the same. The insulin degludec shows a almost insignificant variation of the glucose, and coming to the insulin glargine U300, there is maximum up and downs of the glucose in range. So there is a 14 to 16 hours there is maximum peaking of the glucose, and later there is a up and downs of the glucose in 24 hours. Next slide please. So what about evidence with insulin degludec in hospitalized patients? Next slide. Time action profile of analog basal insulins. Coming to the action, when compared with the other insulins, degludec has fast onset of action, 0.5 to 1.5 hour. The degludec start action, and glargine 300 2 to 6 hours, and with glargine 100 2 to 4 hours. And to attain the steady state, degludec requires 2 to 3 days, whereas glargine 300 requires 3 to 4 days, glargine 100 requires 2 to 4 days. So insulin degludec has a quick onset of action and attains steady state in a similar fashion compared to other basal analog insulins. Next slide. So this is a degludec hospital trial. This is a randomized controlled trial comparing insulin degludec U100 and glargine U100 for inpatient management of patients with type 2 diabetes. In this trial, 180 patients of both surgical and medical were selected with high blood sugars, and out of 180, 92 were put on insulin degludec and 88 were put on insulin glargine U100. And at the end, the results are there is rapid attainment of the glycemic control is seen with the insulin degludec when compared with the insulin glargine in this trial. Next slide. So the rapid attainment of the glycemic control with insulin degludec in hospitalized patients. So this is the baseline 219 milligrams per deciliter, and the day one, after initiation of the insulin degludec, it has come down to 180 milligrams per deciliter, and mean blood glucose is 185 milligrams per deciliter. So degludec was titrated daily in both medical and surgical hospitalized patients. Mean blood glucose on the day one was within the ADA recommended targets with degludec treatment, that is more or less equal to 180 milligrams per deciliter. No episode of severe hypoglycemia seen with the degludec. Next slide. This is the EDO study. EDO study is a prospective observational study. The insulin degludec in hospitalized patients with type 2 diabetes. This study shows what affects the glycemic control, glycemic variability and hypoglycemia. So here in this study, the patients enlisted are 65 and the patients who are put on insulin degludec are 15 and insulin glargine are 50. At the discretion of the clinician, the 30 patients were continued with insulin glargine, and out of 50 on insulin glargine, 20 patients were switched over to the insulin degludec, and put together the patients on insulin degludec are 35 in number. Next slide please. So this IDEO study shows the effective glycemic control. The orange color shows the insulin degludec and green shows the insulin glargine U100. So this graph shows there is reduction of 36.6 milligrams per deciliter in the fasting plasma glucose with insulin degludec, and whereas it is only 15 milligrams per deciliter with insulin glargine U100, and before pre-lunch there is reduction of 30 milligrams per deciliter with insulin degludec, whereas it is 43.8 milligrams per deciliter with insulin glargine U100, and pre-dinner, coming to pre-dinner, it is with insulin degludec 38.9 milligrams per deciliter with insulin degludec, whereas it is 9.9 milligrams per deciliter reduction is seen with the insulin glargine, and at bedtime 37.3 milligrams per deciliter reduction of blood glucose is seen with insulin degludec, 10.5 milligrams per deciliter reduction of blood glucose is seen with the insulin glargine U100. So except pre-lunch, at all levels, fasting, pre-dinner and bedtime, insulin degludec scores over the insulin glargine. Only at the level of pre-lunch, the insulin glargine is able to reduce the blood glucose superior to the insulin degludec in this trial. Next slide please. So, IDEO study in hospital prospective observational study, lower hypoglycemia with degludec. So, the subjects with hypoglycemia percentage, the insulin degludec, with insulin degludec, 80% of the patients shows no hypoglycemia, and 20% of the patients shows diurnal hypoglycemia, and nocturnal hypoglycemia incidence is 0 with insulin degludec. When coming to the insulin glargine, there is 72% of cases there is no hypoglycemia, and the diurnal hypoglycemia incidence is more, 26%, whereas 2% of nocturnal hypoglycemia is seen in the case of the insulin glargine. When then compared to the patients, when switch over from the insulin glargine to the insulin degludec, the pre-switch and post-switch comparison in this slide shows the before pre-switch glargine 70% shows no hypoglycemia, and 25% shows diurnal hypoglycemia, and 5% shows nocturnal hypoglycemia. After post-switch to the degludec from glargine U100, 85% of patients shows no hypoglycemia, and diurnal hypoglycemia reduced to 15%, and there is no nocturnal hypoglycemia is seen with the degludec. That is the advantage with the degludec. And insulin degludec demonstrated efficacy with very low risk of hypoglycemia. Next slide please. So coming to the Simeoni et al. Low hypoglycemia with degludec. So this study shows efficacy and safety of insulin degludec for hypoglycemia management in non-critical hospitalized patients with diabetes. It is an observational study. In this study, 48% of population are more than 75 years, that is elderly population, and with complications like chronic kidney disease 35% and peripheral vascular disease 23.1%. Insulin degludec demonstrated rapid attainment of glucose control with minimum risk of hypoglycemia. Only one nocturnal hypoglycemic episode out of 27 occurred in this study, Simeon et al. Study. Next slide please. So this study, Simeon et al., better predictability with degludec. So permissible glycemic variability measured in terms of standard deviation should be less than one third of the mean glucose. So at the time of admission, the 362.3 milligrams per deciliter standard deviation based upper limit admission glucose, this is outside the range, and 237.1 milligrams per deciliter mean average admission glucose, which is high, and 111.9 milligrams per deciliter standard deviation based lower limit admission glucose, which is also outside the range. The permissible range is between 316 to 158. So permissible ST range one third of the mean glucose. When these uncontrolled blood sugars, when in older patients, when initiated on degludec, there is a significant reduction of the blood glucose along with the standard deviation. See this graph. So at the time of discharge, the SD is decreased from 362.3 to 195.2 milligrams per deciliter, and mean average blood glucose is decreased from 237 to 152, and 111.9 milligrams per SD to 114.8 at the lower limit at the discharge glucose, and overall glucose level is decreased from 203 milligrams per deciliter to 101 milligrams per deciliter, which is very acceptable. So permissible SD range one third of the mean glucose. So degludec showed better predictability in wide range of hospitalized patients. Next slide please. So coming to the second part, ultra fast insulin as component of basal bolus regimen, that is fast. Next slide. So this is the medical rationale for ultra fast insulin approaching a physiological insulin profile even further. So this graph shows the time in hours, and the y-axis shows the insulin action at the meal time. So the blue line shows the from the normal pancreas how the insulin secretion after taking meal, there is a peaking of the insulin. Later on, there is a downward peak, downward slope of the insulin secretion. Then when compared with the regular human insulin, there is a slow increase of the insulin release after meal, and there is sloping of the insulin. And when compared with the rapid acting insulin, there is a rapid increase in the release of insulin after meals, and then sloping of the insulin. When compared with the ultra fast insulin, it mimics just like physiological insulin. The graph shows, the red dotted line shows the ultra fast insulin when given with meals or within 20 minutes after meals. The insulin starts action and it starts peaking, and slowly it slopes down. So the ultra fast insulin should better approach physiological insulin secretion in type 1 diabetes mellitus, and it replaces early insulin secretion in type 2 diabetes mellitus and have a better profile for pump therapy. Next slide. So effective glycemic control with faster aspart. So the blue line shows the, dark blue line is the faster aspart with meal time, and light blue shows the faster aspart with post meal, and light color shows the insulin aspart with meal time. The time randomization since weeks, x-axis, and HbA1c levels on the y-axis. So before first basal optimization, next bolus intensification has to be done. So with the insulin aspart, the HbA1c is reduced slowly and it attains 7.4% from 8.1 to 7.4% at the end, in the middle, and after 52 weeks it attains 7.6%. And when coming to the faster aspart with meal time, it decreases HbA1c from 8.1 to and 7.3%, and at the end of the treatment HbA1c reduced to 7.5%. And with fast aspart post meal the HbA1c reduction is from 8.2 to 7.5 after 26 weeks. So fast aspart given 20 minutes post meal provides similar HbA1c control versus insulin aspart given before meals. Next slide. So the lower risk of hypoglycemia with faster aspart when compared with the insulin aspart. So there is no severe or blood glucose confirmed hypoglycemia in both cases, fast aspart and insulin aspart, and overall hypoglycemia is reduced, is less with fast aspart when compared with the insulin aspart. With insulin aspart is 71.9% and fast aspart is 67.5%, and daytime hypoglycemia is 65.1% with fast aspart and 70.2% with insulin aspart, and nocturnal hypoglycemia is 21.3% with fast aspart and 25% with insulin aspart. And coming to the fast aspart and insulin aspart, overall estimated ratio daytime and nocturnal all show superiority when compared with the insulin aspart. So significantly lower risk of overall and nocturnal hypoglycemia with fast acting insulin aspart. Next slide please. So the flexibility of the faster aspart. So you can give it before start of a meal, that is 2 minutes before meal, or after start of meal 20 minutes it can work. So more convenient in daily life, allows for more precise calculation of dose based on carbohydrates consumed, and reduce the risk for hypoglycemia should a meal be delayed. Useful for elderly patients with cognitive impairment and irregular eating patterns, and also useful in those whose eating behavior is known to vary considerably. Next slide. So uses in wide range of population, both faster aspart and the insulin degludec can be used safely in uncontrolled diabetes and renal impairment patients, and hepatic impairment patients, in elderly patients, and in pediatric groups. They can be used very safely as basal bolus regimen. Next slide please. So coming to the summary, treatment with basal bolus regimen is a choice in managing inpatient hyperglycemia. Insulin degludec in hospitalized patient offers rapid attainment of glycemic targets, low risk of hypoglycemia, low glycemic variability, safety in elderly renal impairment and hepatic impairment patients. Fast aspart is safe, effective, and offers a flexible mealtime dosing. Thank you.